Good morning, everyone, and thank you for joining us. I would like to begin by paying my respects to the lands I'm on and acknowledging the Palawa people of Lowitja, Tasmania, your elders past, present, and emerging. I also acknowledge all First Nations from where participants are joining this webinar and pay my respects to Aboriginal and Torres Strait Islander colleagues here today. I also acknowledge that our topic today, the cultural determinants, is not a new model of thinking, but represents ways of knowing, being, and doing that are tens of thousands of years old. I also acknowledge that colonisation has been so devastating for the cultural determinants of health, but they survive and they thrive. My name is Melissa Sweet, and it is my great pleasure to welcome you to the Lowitja Institute's first KT and coffee webinar for 2021, profiling the excellent work of the report, Culture is Key, towards cultural determinants-driven health policy. Thanks for participating in the poll. It's great to see so many people logging in from around the country. This morning, we are going to hear from three fantastic Aboriginal health leaders: Dr. Ray Lovett from ANU, Renee Brown from the Institute for Urban Indigenous Health, and Kirila Johnstone from the National Association of Aboriginal and Torres Strait Islander Health Workers and Practitioners. Our speakers are now going to tell us a bit about themselves, their connections and their work. Ray, would you like to kick off, please?
Sure. Thanks, Melissa, and thanks to the Lowitja Institute for this fantastic initiative. So my name's Ray Lovett. I'm here on the lands of the Ngunnawal people in Canberra. I'd also like to add and pay my respects to elders past and present. And again, thanks for being here. So I'm a Nyampa man from Western New South Wales. It's good to have a relative on this as well. So I've worked in Aboriginal and Torres Strait Islander health for about 25 plus years now. Hurts me to say that. So I trained initially as a registered nurse, and I also trained as an Aboriginal health worker as well. I've also got a background in workforce policy, so I was involved in one of the first, or actually the first, initiative to increase the number of Aboriginal and Torres Strait Islander nurses. So I was responsible for that in New South Wales. And I also then moved into research through epidemiology training here at the ANU almost 20 years ago. Through my epi training, I did a lot of research work in community control, and after my epi training, I went and worked in community control. And then I came back to research as well and did my PhD. In my PhD, I really started moving towards the cultural determinants, and came up with the idea of creating a study around the cultural determinants at the end of my PhD. And so that's what essentially I've been pursuing since 2013, is conducting large-scale research around the cultural determinants. And that's me.
Thank you very much, Ray. It's terrific to hear about research having impact. Now, Renee, could you tell us a bit about yourself, please?
Thanks, Melissa. And thanks to everyone who's joining us online here today. So my name's Renee Brown. I'm a Nunaka woman from North Strait Rock Island off the coast of Brisbane, or Yagara country. I'd like to acknowledge the many Guri nations that we work across here within Southeast Queensland, and acknowledge our 4 founding member services within the network of the Institute. I have worked in Aboriginal health for 20 years, but I'm pretty much a kid of the sector. My mother's a nurse and was involved in the first Aboriginal community controlled health service here in Brisbane, ACE Brisbane. So I've kind of grown up in and around community controlled health service delivery, and then continued that in my professional journey, where I've worked with a community controlled registered training organisation that delivered health worker qualifications to mob from right across the state of Queensland. And to the point where my journey continued to my work here at the Institute, where my role initially started out mapping workforce and our modular care within the Institute and our network services. But it's kind of evolved as the Institute's journey has evolved to where my main role now is focused on how do we ensure we are embedding Aboriginal terms of reference in everything that we do. So a lot of my work is around kind of systems analysis and the creation of new systems and processes that are informed by Aboriginal terms of reference. So that's a whole lot of different stuff.
Fantastic. We look forward to hearing more in the Q&As later on. And now, Kirila, would you like to tell us a bit about yourself, please?
Thanks, Melissa. Sorry. I'm Kirila. I'm a Nyampaa Barkindji woman, also from Western New South Wales. I'd like to acknowledge that I'm on Ngunnawal and Ngambri lands. That's where I live and work. I have been in the sector for a little while, not long. I'm fairly new, but I, like anyone, I think, grew up around Aboriginal health services and have always understood the critical nature of health. My dad played a significant role in establishing Murrumah out in Broken Hill, which is the health service out there. And since then, my whole life's been about health. I studied my undergrad in public health, majoring in Indigenous health a few years ago. And I'm currently doing my master's in criminology, which I think is an interesting crossover when you look at how some of the base theory is really similar, especially as it relates to mob. I'm really lucky to have been supported through my uni journey by IHA and engaged with them quite strongly through my uni journey. So that was my first exposure as an adult, and now am the policy officer at NATSIHP under the fearless leadership of Carl Briscoe.
Brilliant. Thank you very much. It's terrific to hear about that holistic approach, bringing together research and policy and practice and a long-standing commitment. Now, it is my great honour. Let us please welcome Dr. Janine Muhammad, CEO of the Lowitja Institute. Over to you, Janine.
Thanks, Melissa, and good morning, or in some states it might be afternoon. And a big welcome also to Ray, Kirila and Renee. Try saying that quickly, everyone. Thanks so much for giving us the benefit of your expertise here today, panellists. I too would like to begin by acknowledging the people and the country from where you're all joining us today. I acknowledge elders past, present and future emerging generations for whom our collective work is so important, particularly today's topic, which is our cultural determinants. I am a proud Narungga woman from South Australia, also an ex-nurse, but I'm working and living on the lands of the Wurundjeri and Bunurong's peoples, and I'm also an Aboriginal health worker, but I'm also proud to be the CEO of the Lowitja Institute, which last year fulfilled its long-held dream to become Australia's Aboriginal and Torres Strait Islander community-controlled National Institute for Health Research. And I'm very glad and excited to welcome you all here today to what is Lowitja's first KT and Coffee webinar for 2021. So KT and Coffee webinars are knowledge translation events that aim to share the Lowitja Institute's amazing work to support collaborative discussions and to generate new and emerging ideas for Aboriginal Torres Strait Islander health, even though the cultural determinants of health have been around for as long as we have, millennia. As many of you know, knowledge translation really has been at the heart of the Lowitja Institute's work since our inception. In fact, as a commissioner of research, we're probably the only institute to actually fund knowledge translation as a part of our project funding. A little bit about our patron, Dr. Lowitja O'Donoghue, and many of you who know her would know that she did not mince her words. And when she lent us her name, she told us that she wanted us to be an institute that really did achieve real, tangible and immediate outcomes, not research that would never be applied, that would sit on a shelf and only serve the writer. This meant, she said, that the point of research must always be questioned. Whose interests does it serve? who will benefit, and who is most importantly asking the research questions. And the same for us at Lowitja applies to the policy space. And so our first KT and coffee has been guided by our new report, as Melissa said. It was published earlier this month and it's titled Culture is Key. A link to the report can now be found in the chat feature of this webinar, or if you're watching a recording of this webinar later on, you can find the link below the screen. As most of you will know, for Aboriginal and Torres Strait Islander peoples, the cultural determinants has been an essential part of our identity, really anchored in our ways of knowing, being and doing, and have continued, as I said, for millennia. And as you'll hear today, I'm sure from the panel, culture is a protective factor for Aboriginal and Torres Strait Islander health and wellbeing, and it needs to be integrated and valued within health policy frameworks and, of course, in our programs. Aboriginal and Torres Strait Islander peoples had advocated for a culturally centred approach to health and wellbeing for decades. Any of you online that has worked in Aboriginal and Torres Strait Islander health knows that our model of health is holistic. Yet this has often been neglected in government approaches to our health and wellbeing, and that's because our cultural determinants of health do not align with dominant culture or the normal or Western perspectives, and therefore are not fully understood or appreciated, particularly by policymakers. An important point is that ultimately, if policymakers do not understand and embrace cultural determinants, they will dismiss our culture for theirs and not find and fund our priorities. This will cause and has caused and is causing deep harm for our health and wellbeing. But this report, which brings together and adds to the work of many leading Aboriginal and Torres Strait Islander researchers and thinkers, including here on our panel today, provides a blueprint to putting culture at the core of the policies affecting our mob. It shows how the cultural determinants of health can and must be implemented into policy and practice. And it comes at a really important point in policy making, providing real opportunities for governments to make a shift. Both the new Closing the Gap National Agreement and the current refresh of the National Aboriginal and Torres Strait Islander Health Plan really provide and offer a unique opportunity for governments to recognise and invest in a whole of government policies that are driven by the cultural determinants. This includes the development of a whole of government Aboriginal and Torres Strait Islander cultures policy that respects the centrality of culture to Aboriginal and Torres Strait Islander health and wellbeing, reform to the way Aboriginal and Torres Strait Islander health research, funding, evaluation and reporting is done to empower community-driven policy and decision-making, and commitment. One of my favourites, a commitment to historical truth-telling as an important component to creating health systems that are free of racism. The framework for implementing the cultural determinants is laid out in the report, and it involves shared commitment and collaboration across government, community-driven holistic approaches, operating on the key principles of Indigenous leadership, strengths-based and rights-based approaches, and a recognition of the impact of the social determinants of health and, of course, racism on health and wellbeing. So I urge you to read the report and follow the fantastic work of our panellists here today. And to end this little bit of information that I wanted to share with you, I want to end with a quote from the CEO of NATSIHP, Craig Ritchie. It's quite pertinent, I think, to today's discussion. He says that culture is more than practices, things like art, song and dance. Culture is a framework of ideas, truths, norms, values. It is about what matters. It is about how people make sense of life and the world. Thank you so much for joining us here today. I hope I see you again. So over to you, Melissa, to begin our panel discussions. Thank you.
Thanks so much, Janine, for setting the scene, demonstrating the importance of this report and its recommendations, and also these discussions. So Ray, if we can come back to chatting with you, can you tell us a bit about the Maya Kauai study and what inspired you to do this work?
I guess fundamentally there were two reasons. So the first has sort of been alluded to in a lot of ways. So it's, I always talk about this as it's personal for me. So it's about family and connection. And that leads to the second kind of reason, which is just sheer frustration. So, you know, my family history is probably like many others in this country, particularly, you know, my Aboriginal family history. And I got really frustrated, you know, because what the evidence tells us in research is that about 1/2 to 2/3 of what they describe as the gap in health outcomes, we don't actually fully understand what is contributing to that. So, you know, but we constantly hear this rhetoric that if we just go to school, get a job, and do these other things, that we will have the same life opportunities as everyone else in this society. But fundamentally, that's incorrect. You know, when the evidence tells us that, when we still don't understand. So I, as an Aboriginal person with a PhD compared to a non-Aboriginal person with a PhD, so, and a job and all of those sorts of things, there are still forces at play that we currently don't understand that will contribute to my life being shorter, right? If we take that ultimate closing the gap indicator of life expectancy. So then the second part of that frustration is not understanding what's contributing to that. So we know that, you know, those things around education, employment, and those things do matter, but only about half as much. This other half we don't understand at all. So that led to my frustration. Well, we actually need to understand what those other things are. And so I had this sneaking suspicion that it was, well, I still have these sneaking suspicions, that it's the suppression of our culture and the processes that have gone along with that, the historical trauma that has been inflicted on our families. And so that's historical, but there's also, it's ongoing and contemporary as well. It's just in different forms. And so that really sort of led to this, the development of my choir. And but also trying to bring in those other elements of dominant cultures that is quite damaging to us. So Janine's already alluded to that. So we need to understand how much Aboriginal and Torres Strait Islander people are exposed to things like racism and those other things. So that's really where it comes from. And I really like that point that Janine made about culture as a protective factor as well. That's a big part of this. How I'm really interested in understanding through this research how our connection to country, language, family, kinship, those systems, how they actually protect us or buffer the onslaught that often many people feel from broader society. So that's really important. And I think, and our evidence is starting to show from my choir that these factors, these buffering effects of culture are really, really important. And those harmful effects of colonialism are there. So it's about those two things for me.
Thank you very much. I've been reading in this new report, and it describes the 6 domains of the cultural determinants of health.
Yep.
Tell us a bit more about these.
Yeah, so I sort of alluded to a few of them there. So I mentioned our connection to our country, and that's whether we live on country or we live off country. About a lot of us, we talk about we needing to go back and recharge and those sorts of things. So how from an Aboriginal Torres Strait Islander perspective, whether it's islands or mainland, how do we conceptualize those things? So that country is a big one. The family and kinship and community, cohesiveness, connection, those sorts of processes. So that's another one. And with that, sort of highlighting, again, Janine's point around what Craig Ritchie said, it's more than practice. How do those beliefs and knowledge systems, how do we learn those? How do we embed those in our lives? And how do we express them? So that's another one. We also then do have the expression of our cultures. So that can include the art, dance, and those sorts of things. So there's one about beliefs and knowledge, and then there's practice. And within that, we've got things like language, language reclamation, and even how language has changed over time. And then the final one is much more around self-determination and leadership. So how do we take charge? How do we control the agenda ourselves? So that's at the individual level, about people feeling they are in control of their lives, or whether it's at the community and family level, about whether they feel that they are leading the best life they want to, the way they want to. So they're the sort of broad 6 domains that we talk about from our research and our literature review. But there's much more in a report for those that are interested, that it's published on the Lowitja website, called Defining the Indefinable, because we were told that we can't really define these things along the way a lot.
Thank you so much. And so clearly, based on what you've said, it's very challenging, transformative for dominant sort of culture ways of doing policy or research. So what have you learned about what are the barriers and enablers to embedding the cultural determinants of health into health policy?
Yeah, again, I think there's 2 major issues. Janine's alluded to the first, which is around definitional issues. So if people think this is intangible stuff, which is often how it's talked about, culture is an intangible thing, then people can't sense, feel, touch it, so they don't know what it is. So there's definitional issues, and that's part of the reason why we did the big literature review a couple of years ago, so that we can actually define some of these elements. And like I say, all the way along, we get told we can't define these things. I don't know why. Maybe it's just my epi training. I don't have an anthro background. But then from moving from definitional issues to data to describe those things. So I think they've been the big 2 issues that have impacted on why it's been hard to get traction in the cultural determinants. So the first is, well, what is it? So we have that now. We have the 6 domains, and under that, we've got a whole bunch of different things that we describe and how they're important. So the next stage was really the reason for my QI is, well, if we take those concepts, those ideas, and we talk to Aboriginal people around the country like we did for 4 years, to say, well, how do we ask about that? And how would you report that to us? So that's what we did. And so I think now that we've done the definitional side of things, we've asked people to tell us how we can ask about those things. We are now able to describe and quantify those things for our lives. And now we're seeing much more traction, particularly in the policy landscape at the moment. So they've been the 2 big issues, but it is changing.
When you say getting much more traction, what would be an example of that? Or
well, lots of people on this webinar would be familiar with the revised National Aboriginal and Torres Strait Islander Health Plan going forward, in that for the first time we're seeing the cultural determinants as the centre of that national plan. So that was, we started seeing iterations of that in the last plan, not really described out too well because we were still in the sort of defining phase. But now we've moved in the revision to those plans for the plans going forward. We're seeing much more work, and it's probably, partly from the literature reviews and the work that's been going on over the last 5 to 10 years in particular, and reports like this one that we're discussing today, that it's becoming much more embedded within our policy landscape, particularly health.
Brilliant. Thanks so much, Ray. Now, a really great follow-on from Ray's presentation to hear about Renee now, about, I guess, more at an organisational level and in practice. So, Renee, can you please paint us a bit of a picture about the important changes that IUE have made to embedding the cultural determinants of health within the organisation?
Thanks, Melissa. I think it really kind of, for us, came down to reorientating our perspective about how we approach Aboriginal health. I think sometimes we get caught up in the game and think about ourselves within the system, and that, has been kind of as a result of our health services needing to compete for funding, being driven by a government policy which doesn't understand our terms of reference or, the principles of what is community control. So for us, it was really a conscious decision to really think about what are those principles of community control and move from that point of rhetoric into actual practice. And the other aspect too was an acknowledgement that our community controlled health services started from Aboriginal terms of reference. They mobilised through the collectivity of our people coming together to right a wrong, of course, but it was about the ways in which we did that, which also determined how health services were delivered. But obviously, over the last 40 odd years, that changed because of government funding. So we've seen siloed approaches to healthcare being embedded within our health services driven by funding. We saw disconnection amongst our community, particularly here within Southeast Queensland, where our 4 founding member services were created from one organisation and one community. We got to the point where our CEOs didn't even know each other. Our communities weren't working together. And we'd also gotten to the point where I think we failed to recognise our own cultural accountability and obligation to our people. We kind of hadn't moved out of our patches. Our community had grown, but we hadn't kind of moved with the times because in a way we kind of stagnated because we were in this cycle of fighting for survival within our health services. Through other reports like, the overburden report, all of those things have become a bit of determinant for how our services then only think of ourselves as service deliverers, not as community controlled organisations which should be driven by Aboriginal terms of reference. So for us, it was really about coming back to and articulating what are our terms of reference from an Aboriginal perspective. And particularly want to acknowledge too one of our community members, a senior woman of the Comber Mary, Auntie Mary Graham, who has been involved in our journey at the Institute, and great philosophical and political mind, nationally, internationally, but particularly within our community, very highly revered. But Auntie Mary said, that we used to run this country and we did so successfully for 60,000 years. And that means from a sociological perspective that we had all these systems and processes which supported a healthy and strong and dynamic civilization. What changed obviously was colonisation. But, I go back to the point of getting caught up in the game. The thing of colonisation is obviously the subjugation of our minds and how we approach things and think about things. So for us, it was really about coming back to our terms of reference and having those terms of reference reorientate our own ways of thinking too. So I suppose in terms of some of those important changes, that's probably been the fundamental part, that our foundation is driven from Aboriginal terms of reference, and from that then provides a kind of decision-making protocol kind of thing for us about how we then approach everything else that we do within the Institute's network of member services. And I'll just go on to, I think that always reminds me of that saying that you once quoted, Janine, too. For the master's tools will never dismantle the master's house. And I think that's the kind of critical lens that we need to take to how we think about culture as a key determinant, not only just in terms of service delivery, but how do we think about it from a systematic approach as well. And so from that, the Institute, in partnership with our founding member services, has done a whole heap of work about how we approach governance too. How we look at strategic relationships and are they really reciprocal? Do the principles, our relationships with the PHNs, the HH, the health service districts, other NGOs, do they align? Are they aligned in, what we are seeking to achieve for our people here? It informs how we approach workforce development, how we look at HR systems, recruitment selection, performance appraisal, professional development. It's also informed our the next iteration of our system of care, where we're looking at that real relational approach based in Aboriginal terms of reference, and how that informs our model of care. And we're doing that in partnership with Ray. Ray's involved in that too. And I think that's a really key point too, that it's not going to be about a Western perspective of primary care. This is about proper Aboriginal primary health care based in relationship. Then there's a whole heap of work done around how we deliver programs, how they're informed by Aboriginal terms of reference, and particularly research as well. So that's a lot, I know.
That's a lot going on, really foundational, important systems work. I'm just wondering what differences these changes have made. Can you describe that in some ways for the audience, and also not just whether you're evaluating, but I guess how you're evaluating them?
Well, I think it kind of comes back to that point of that we need to think of ourselves as a system, not within the system. So within that, it is a very sociological perspective that we think about, our society. So we kind of structure how we do that. So from the strategic, societal strategic workforce and operational perspective, but just like, defining the cultural determinants of health, and you're trying to evaluate that, that's a mission and a half as it is, for us to define that for others. I think the other, the thing of evaluation is trying to evaluate a societal approach, which is what we're doing here within our communities within Southeast Queensland. It's a massive task. So just like the social determinants of health, culture being a part of that bigger framework, what we've done is evaluate a number of different kind of approaches and programs. So things like our birthing in our community program, which has recently just had an article published in the Lancet, an international journal. And that evaluation is shown through, proper partnerships between community control and tertiary sector that is community-based, driven by the relational terms of reference, so culture as a determinant, that what we'd be seeing is a halving in preterm birth rates for our mob. The other thing from that then is that we've then been able to demonstrate the success of that model being driven by our mums and fathers in community, that we're now influencing the other HHSs, the other health hospital service districts within Southeast Queensland, where they're implementing their own programs too. So we're working in partnership. So we're not thinking about ourselves within the bubble of community control. We're thinking about ourselves in terms of the territorial integrity of what goes on within Southeast Queensland for our mob. And then, there's a whole heap of different things that we are evaluating, in terms of things like reorientating our mob accessing allied health services. So rather than care being directed by a GP or by an allied health provider through their own lens, what we ask is for a reciprocal nature within care, and have our allied health mob negotiate goals for how care is to occur and what the outcomes mob want them to be. So what we've seen from that is, by measuring that kind of relational and reciprocal approach to care, that we've seen between 50 to 70% across a broad spectrum of allied health providers of goals being improved upon by mob, you know. So this is about respecting the autonomy of our people, you know, and that's, I think, also about breaking the dynamic of Western concepts of healthcare and having it being driven by our terms of reference and the needs of our people too. So you can see how this kind of terms of reference then filters up and in and, you know, across a whole heap of different aspects of what it is that we do. And they're the difference that meaningful and transformational outcomes for our mob is what we seek to achieve.
That's brilliant to hear about that work. Thank you very much for sharing. Now, Kirila, to a topic that I'm sure is very close to your heart. How can the cultural determinants of health influence the way we recruit and retain Aboriginal and Torres Strait Islander people in our health system?
Oh, I think there are so many ways, but they're particularly relevant when we talk about burnout. So we hear from our workforce all the time that work doesn't stop when you leave the clinic in the afternoon, because you have cultural loads that you carry with you all the time. And also the nature of the work that you do is highly personal. So Aboriginal health and Torres Strait Islander health staff and workers working with mob is always going to be a highly personal job, because you're working with family and you're working with issues that are relevant to your own experience. So we always know that you can't pour from an empty cup, but you can't keep those cups full in workplaces that don't recognise the whole health and wellbeing of their staff. I think we need to look at leave entitlements and workplace arrangements that understand the cultural loads of the health staff. So sorry business leave, and a recognition of the entire life of the person that also services that community. But also we need like effective and sustainable career pathways that recognise that Aboriginal people are the experts of Aboriginal health. And so they need to have pathways to take those leadership positions, because if there's not, it's only going to be volatile environments and unsupported environments that continue to foster in these health systems and health services.
Thank you. Yes, you can feel the personal passion and commitment of everyone where work is so important. Now, can you tell us a little bit, Kirila, about why the roles of Aboriginal and Torres Strait Islander health practitioners and workers are so important?
We love our workforce, and that's probably like the silliest thing to say as someone that works at the peak body, but we believe our workforce is so critical to delivering effective healthcare to mob, because they play the role of the cultural connectors and the system navigators, which is so important in a big health system that can be often confusing and unforgiving. We also believe that our profession, in the health system at least, is actually one of the most enduring examples of self-determination. It's a profession that was created by Aboriginal and Torres Strait Islander people to service our own people. And so what better way to prove that we can do that? And I think the impact of that has been seen specifically through COVID, when we know that our health sectors and community control specifically has really led COVID response around the world. And we believe our workforce played a critical role in that. We know that in remote and rural communities, our members are sometimes the only consistent health staff. We have health services that have practitioners and specialists that operate on a fly-in, fly-out basis. And so when we know that our mob value trust, and we know that our mob value consistency, a consistency in healthcare staff is also really important. And that's the role that our workforce plays. I think also it's interesting, I think there's been a history of our workforce being quite underutilized and undervalued in the wider health system. But recently you've seen that there's recognition for the scope of work that our members can undertake. And that's been really clear through even just some recommendations coming from coronial inquiries and inquests have specifically recommended that health workers and health practitioners be present within the justice system. And so there's a recognition of the flexibility of the role, and that it's not necessarily clinical all the time, but it's that interpersonal relationship and that cultural connection that's so vital.
Thank you so much, the passion. And it's wonderful to hear people talking with such warmth towards workforce that's really reaffirming and reinforcing, and the COVID example is so powerful. Now we'll have some general discussions with our panel. So we'll have Ray, Renee and Kirila on, as well as Janine. So hello everyone, got your mics on. Now, Ray, just drawing on your experience with the Maya Kauai study, how does having Indigenous data governance principles in place change the way that health data and research is used or applied?
In a big way. So I was very fortunate, particularly as we were, there's some 12,000 Aboriginal and Torres Strait Islander people involved in the study now. So it's really important that that data be used for the right purposes in the right way. And so as people were enrolling and continuing to participate in the study, we were fortunate in that we were able to work with some key thinkers around developing some principles around how we would want to make the data work. So first in that was being really responsive to community and community organisations around the data from the study, in terms of what data did they need for community development, for nation building, nation rebuilding, those sorts of things. So that was really, really important because often our data as it currently sits at the national level, particularly if we think about ABS, AIHW, our national statistical agencies, communities and organisations have very limited access to that data. So we hand over lots and lots of data, but how that actually gets returned to communities and community organisations for their governing purposes is very, very limited if we think about that. So we wanted to reverse that in that for our mob, that these data be available and for use to make decisions at local levels. So the project that Renee briefly mentioned when she talked goes to that point. So we're working with IUE around their models of care and how clients engage with the service in a different way and how that improves outcomes. So we do things like that with MyQI around returning data, repatriating data that way. So it helps improve things. Right to working with communities around their social and cultural determinants and community indicators that they want to develop to advance their community. So we do things like that as well. So it's really about being responsive the other way. The other thing that it does is it stops inappropriate analysis. So the point I wished I had made at the start was a lot of the misinformation that goes on around our health is that in some way we're biologically inferior, and that explains the disparity in health outcomes, and that is just not true at all. So we talk about race as a social construct, not a biological one. So often those two things are really conflated and confused, and it is so frustrating to hear that very, very often, I have to say, and particularly from clinicians. So we have some protocols around analysis, how the data can be analysed. So we don't release the data to researchers willy-nilly. They have to tell us how they're going to analyse the data. We do technical reviews of how appropriate that data analysis and the method is. And the committee, there's a 12-member all Aboriginal Torres Strait Islander committee that sits on our data governance committee, can reject any inappropriate analysis like that. So using, indigeneity, Aboriginal Torres Strait Islander status as a predictor for, say, some negative health outcome, we will not allow that because, again, it reinforces that biological kind of, well, I call it biological racism. And it's really about conducting appropriate analysis that is strengths-based, so it reinforces indigeneity or cultural determinants as a health protecting, or we call it salutogenic factor. So the third point is, I've mentioned the panel that sits on it. So that panel constituted the data principles themselves. So we worked with them from the start. The principles just didn't exist. So we worked with them over 12 months to say, well, what are the principles under which these data will be allowed to be analysed and used? And so they created these principles, that panel. My job as the study director is to create the paperwork and the systems for those applications for data to go up to the committee, and they make the assessment. Even analysis I want to do in the data, I have to put in an application to the committee, and they can reject an application from me. So it's making sure that that panel, that Aboriginal and Torres Strait Islander people have ultimate control over what data is analysed, how it is analysed, and whether it's appropriate for public release. So it turns the whole system that we've currently got on its head. When we work with community organisations, we work with them around the data that they want, and that's their data. It's not ours. I'm the custodian of this data from 12,000 people. They've entrusted me to look after these data. So I've got a lot on my shoulders. And so, of course, you don't want to mess with the mob. So we have to make sure we have really good procedures and systems in place. Sorry, that was really long.
That's great. Thanks so much, Ray. It's good you've got a strong set of shoulders there, and that was really terrific to hear, you know, the many reasons that Indigenous data governance is important and interconnects with the cultural determinants. So Renee, could we come to you? One of the points raised in the report is about the need to shift where and how health policy is made. So what do you think about the role of ACCHOs as policymakers?
I think it's a really important point in terms of, you know, if you go back to what Ray was just talking about, you know, what I'd said previously, and, you know, what the report says too is culture is a determinant. And if we think about, you know, from that perspective of, you know, the self-determination, there is an important part of valuing the regional variances of our mob across this country. You know, that policy is not a one size fits all, that we have differences in how we do things. And I think that's a part of then respecting how and the way in which things are done regionally then too, that, you know, the needs of our people here in Southeast Queensland are very different to mob up in far north Queensland. And particularly, you know, if you think about, you know, the systems that surround us as well. And that's also, you know, means a difference in investment as well. But I also think that it needs to be, you know, policy needs to be developed through reciprocal relationships with mob, particularly, you know, our ACCHOs. But I also think the critical point of that too is that, you know, it's for us to also think about ourselves as the owners and runners of country and do things from our terms of reference and not be consumed and driven by, you know, government initiatives as well. That, yeah, our accountability to our people is the best policy driver. And, you know, that's the whole point of culture as a key determinant. But I also think too that we need to think beyond service delivery and think about ourselves as organisations, as people within community too. That it is about our organisation's reciprocal relationship with our mob too. It's not a one-way street. What we do with our people is about, you know, the strength of our people too. And it's not just about that sickness, you know, going back to that salutogenic approach that Ray just mentioned. So I think reorientating our own perspectives too is critical in that. But I definitely think, you know, the current arrangements need to change, you know.
And this report and your comments and discussion today provide so many fantastic directions for that change. Kirila, could we come to you? As a young Aboriginal woman, what is your vision for health services 20 years from now? What would you like to see?
I think if we're talking absolute gold standard service delivery, I think all health systems and services need to be guided by Aboriginal and Torres Strait Islander ways of knowing, being and doing. And not just as they relate to working with mob, but I think as they relate to working with everyone. I think what we have done for generations is in understanding health holistically and understanding the health of a person as connected to what they value and what they believe, while it's really natural for us, is quite innovative in a Western context. And that innovation is probably only matched by other First Nations communities globally. I think one of the greatest examples of that is the rise and the trend of self-care. And I think it's quite funny sometimes because realistically, we've been doing that for as long as we've known. That's what engaging in ceremony is for us. Like, we know these things, and Western contexts and systems are only just catching up. What I think would be really effective in having these frameworks lead health for everybody is that they're relevant to everybody. And we will always have space for biomedical health in terms of fixing our broken bones and stuff, but we need to move from caring from the body to caring to someone's being in totality. And I actually think Aboriginal and Torres Strait Islander people and theory and academia and research are really key to leading that, and is actually best placed to lead that for everybody.
Thank you, Kirila. There's some questions coming in from the hundreds of people who are participating today. So if it's okay with you all, I'll just throw one. There's one in particular for Renee. Is there a plan for expanding your seminal work in Queensland and community groups to working with health departments and hospitals to provide care determined by the needs that are determined by mob community? Yep, here you are.
2020, no lessons learned, still not unmuting. Look, I think that's a really hard question to answer because I think fundamentally you have two very different perspectives of how you approach things, how you do things. There's, as an institution, there's kind of determinants of how that institution is structured. And often it is from a practitioner lens. And we've already been talking about the whole thing of holistic health and, and not siloing approaches. I think the difficult thing of hospitals is that it's very siloed in its approach. And it's hard to influence very large institutions too, because what it requires is a fundamental rethink of how your terms of reference. And I don't think we can do that work for people, for institutions. We can work in partnership with hospitals, and we do that already within Southeast Queensland. We have a program called IUE Connect, where we're facilitating those pathways for mob out of hospital and into, back to community, to a primary healthcare provider. And we have a partnership with the Queensland Children's Hospital, where we're looking at the services that they provide and trying to work with their leadership around their terms of reference and how we can engage in proper and reciprocal relationships. But I think it takes leadership too. There has to be a fundamental change into how people think about health, just reinforcing what Kirrilaa was just talking about too. And I think that's been a long embedded kind of psychology too within hospital. So we're willing, but it's also about whether there's the leadership there and there's a want to drive fundamental and transformative change, because ultimately that's not our work to do.
Thanks so much, Renee. I'm conscious there are plenty more questions there, but I'm also conscious of the clock. So it's really fantastic to see that you've stimulated the questions and the discussions. And I'd just like to really acknowledge and thank the panellists and everyone who contributed. And from me, a personal thanks to the Lowitja Institute for the opportunity to be part of your KT and Coffee webinar this morning. Now, it's my pleasure to hand back over to Janine for some closing remarks.
Well, as a research institute, I had a close observation, Melissa, and that was that this is KT and coffee, and none of us had coffee in our hands except for Dr. Ray Lovett. So someone read the script. Note to self for next time. But on that note, friends, old and new, thank you for taking the time out of your work day to join us. I hope you had a coffee in your hand or a cup of tea, whatever your poison is. You know, what I really want to impress upon you is to please read and share the report and keep engaging with us via our online platforms, that's website, social media. There you'll find out much more information about Lowitja Institute, but particularly about our upcoming KT and coffee. And if you would like to be a part of shaping our next topic, we would love you to answer the survey that's about to happen on your screen soon. And also the best way to become involved with the Lowitja Institute is to be a part of our membership program. And a link will also be in the chat for you to have a look at. And so you can sign up to the Lowitja Institute. Can I please, in closing, thank you, Kirila. It's been a pleasure knowing you as a young woman growing up in the sector. Renee and I were once that. Hey, Renee, long-term friend of mine, Renee Brown, and love to your mother, Mary Martin, who's an absolute mentor of mine and absolutely spoke into this space. Ray Lovett, for your leadership, your vision for commencing this very important work, not only for the Lowitja Institute to KT it out to all of government and to impact on, you know, policy and programs and eventually health outcomes for our mob, but to also give this back to our community and say, yeah, we knew it for millennia, but now we've got your work behind us, Ray. Thank you, and thank you, Melissa Sweet. I wish you all a happy and healthy day. Thank you.